And so I just wanted to ask who was waiting till today to work it up? That way everything was fresh in your mind. Did anybody wait until this morning to try to do it? Okay. What about on the other campuses? Did anybody try to wait until this morning to work it up?
Right. It worked on it while I was watching the Super Bowl.
Anybody in Savannah? Any issues there?
No.
What about Albany
No.
and Augusta?
No issues.
We didn't have any issues.
Okay. All right. So just take about 5 minutes or so. Get together in your group. Talk about your problem list that you came up with, and see if you guys can collectively come together with some consensus answers, and we'll get back together after that.
EHR Go.
We've already talked this today.
We've talked this thing. Yeah. Wait, what were alternate questions? Aubrey.
Aubrey wrote it down.
Did you guys alternate?
What is your memo?
Yeah, the drug related. Alright, well, I'm gonna go get my food. What is the primary problem? Yeah, I would say this is what's going to happen in the practical. I can tell you all the problems, I just don't know what's the most important.
I think it's at first, then dementia.
Right? Like last week, I definitely ordered in we need to fix her diabetes, and then the yeast infection will fix itself, and they'd be like, wrong.
Yeah, that's what I was thinking, because if her glucose goes down, there's no need to keep prescribing.
Yeah. And there was a crap ton of glucose in the urine, and I'm like, you're literally
That's why she
feeding
keeps
the
getting
bacteria what they want. But she was like, no, it's her vulvovaginal candidiasis. Okay. Rebecca. Yeah, I need to get I'm gonna try. Okay, I'm gonna start doing this with Saturday, but I'm gonna do it with the gloves. Cassie, I know. I was like, okay. Well, I'm gonna try it with the gloves. But I do a walk in something with my ear pops. But I like deliberate and well, here's the other thing.
I am just going through my trash to see if I can empty the trash.
I'm religious and
I know you are.
So I tracked it after when they go all the way back to
What we were talking about.
I'm like, where's the logic in it?
I also just deleted something out of my iCloud Drive. I don't know what it was, but usually my iCloud Drive stuff is important, and I can't remember what it was. So because I still have my APP, but I didn't delete it on here.
It should still show up.
Oh, really? Oh my god, that makes me so
There's
sad.
nothing in there. It was a folder.
It's not 73. How old is he right now?
I would say like 53, 26. Close enough. There's a Terrell Davis, he's a former run back, and he won.
No. But he doesn't consider this. Yeah, Ombre.
The basketball player from last week.
Do you think that
Do you think that maybe, does that discontinuing aspirin thing, was that maybe from the thing that Dr. Stone was talking about last week? That she was like, there was a new trial or
Yeah, that's
something?
what
Dr.
Newsom
Newsom?
was. That's for triple therapy. They're dual antibodies and anything like that. He'll just discontinue the aspirin, but he's only on, he needs the, I think.
Wait.
I think he needs that.
Oh, is that, I put it?
I put it
But I
because I was
don't
like,
think
this is
you need to
fine.
discontinue. Yeah.
Yeah.
It's like two different things.
He needs very basic. app for the like guidelines. There's like an AHA guideline app. So you see like someone who looks at them.
I don't have it. I was gonna buy this other app that's
This
called.
is free and it updates.
Ooh.
You don't even need internet.
What's it called?
AHA guidelines.
There's another app called Journal Club where you can look up like actual clinical trials, but you have to pay for it. But oh, this is so cool, and I feel like this is like the most annoying stuff that you have to like keep looking up anyways.
This is like the most common thing.
Wow, it has everything.
And it updates them really quick for you and it's free.
Thanks, Aaron. We're going with AFib.
I didn't put dementia. I put dementia as like part of the work just because.
I think because you presented confused and everything.
Yeah, I feel like
I'd say two primary problems.
I was like leaning towards it being more important because that was like his chief complaint. So I was like, maybe they're like going off the chief complaint because the lady's chief complaint last week was her yeast infection.
It's like if you don't fix his chief complaint, then there's a problem.
Well, then what is his chief complaint? Hypertension? I mean, he doesn't
No,
have
he
a chief
came in
complaint.
being like confused.
He didn't come in because he was confused, though. I don't know. That's where I'm.
He was complaining about like being confused though.
Yeah,
So I was
yeah.
like,
He was
okay.
just coming for a follow-up and he was confused, so that is a one of the primary problems.
He says this is all
It's one of the high quality. It's one of the high quality.
It is. She said it's only $45. But I had it free on my account because I've been a member for months and permanently get something for free. The Mystic But you get your little nose. Oh. I'm going to throw one in the trash.
Don't throw that away.
Yeah, I don't know why a lot of things are in the trash unless they're duplicates.
Well, it's probably because you deleted messages.
I gotta say that too. You eating something off the floor?
You know, shower. It's called a rag.
Texas.
Yeah.
This is the first Texas trip I remember. I ate cheese at
I gotta find out what I deleted from iPhone first.
Go to this one, Cloud Drive, and go to recently.
When that first started talking, he's like,
I said deleted them.
For what?
I was like, wait.
App that.
I really thought that's what he was about to say. It's Monday. You should do that during the middle of work.
bring like so much food on Monday.
I don't know what it is, but like I don't really eat it. And then like midday hits and I'm like, oh my god, I'm so hungry.
You want to kill somebody?
And I'm like, well, if I just ate breakfast, I wouldn't have this problem. But
I still feel like I would.
I feel like eating breakfast makes me hungrier, so I'd rather not. That Erica showed me.
Who?
This app that Erica showed me has like all the AHA guidelines.
Heck yeah. What is it called? AHA guidelines?
On the go. It's free.
Oh, crap.
And it updates. Every update.
All right, can everybody hear me okay? Can everybody hear me okay? Is that better?
Can you turn it down?
All right, what about the other sites? Can you guys hear me?
Yes.
All right. I'll take absence of answers as everything's okay. So did everybody have enough time to talk about their problem list that they came up with individually in their groups?
See.
Okay. So let's get a group here in Athens to tell me what your number one priority problem was and why.
We said it was lack of anticoagulation because it's high risk for stroke, and he's already had a stroke.
Okay, so in Athens he is a high risk for anticoagulation, or he needs anticoagulation, and he's had strokes in the past. So what is his indication for anticoagulation that you found?
He's got a CHADS VASc score of 6, and he's indicated for it as long as it's over 2.
Yeah. So his CHADS VASc is 6, which is really high. Let's see, somebody in Albany, what was your number one priority problem?
You know what? It was the AFib.
Okay, all right. Anything different on the other campuses? Did anybody pick a different problem besides his AFib and need for anticoagulation?
I put the dementia because he presented with confusion and agitation.
Okay, dementia, and he presented with confusion and agitation. Okay, let's see. So you think that takes priority? So what made you think that took priority over his atrial fibrillation and not being on anticoagulation?
Because he's symptomatic.
Symptomatic with dementia, okay. Could that potentially be some side effects of past stroke, or maybe a current stroke if he has confusion and agitation?
I suppose.
Oh, okay, all right. Yeah, so potentially, right? So what guidelines, if you picked anticoagulation as your first priority problem, what guidelines did you guys look at to determine if he needed anticoagulation? And just kind of walk me through your steps there.
AFib. I don't know what they're called. Hold on.
I looked at the 2019 AHA, ACC, HRS focused update of the 2014 AHA, ACC, all that stuff. I looked at that AFib guideline.
Beautiful, yeah. So we definitely want to use those guidelines. So now we know he has a past medical history of stroke, 2 strokes, I believe. And we know that his CHADS VASc is 6. That's what you told us. So what components gave you that 6 of the CHADS VASc score?
All of them.
Smoking.
Basically.
Yeah.
Like all of them.
He has heart failure, hypertension, diabetes. His age is 75 and he's had a stroke.
Yes, so 1 for heart failure, one for diabetes, one for age because he's between 65 and 75, right? One for diabetes, that gets us to 4, and then 2 for strokes, that's 6. And the group here in Athens said that he's indicated for anticoagulation. So so that's kind of your assessment, right? He's indicated based on his elevated CHA2DS2-VASc, history of multiple strokes. So what did you guys decide to do?
We did a Apixaban, 5 milligrams BID.
Okay, so Apixaban, 5 milligrams BID. Anybody, let's see, anybody in Augusta pick anything different for his anticoagulation?
I don't think so.
I feel like, but I don't remember where I read it.
Say it and say I found it in the literature.
Yeah, say it.
Nobody picked
I
anything.
found warfarin has like level A evidence, but I can't remember which guideline I read it in.
Okay, so we have a team that picked warfarin. So what dose of warfarin did you start Mr. Davis on?
I did it
5 milligrams.
5 milligrams daily.
Okay, that's cool. 5 milligrams a day. So we'll get to the monitoring for that in a second. Anybody pick anything besides warfarin or Apixaban on any of the other campuses or in Athens?
I picked rivaroxaban just because it was once daily dosing.
Okay, yeah, so what dose of rivaroxaban?
15. I think 20.
Okay, yeah, 20 milligrams a day. Make sure you take it with food, for sure. So how did you determine that that was the appropriate dose for Mr. Davis? What do you need to look at when determining dosing of rivaroxaban?
Renal function.
Yeah, renal function, right? So what was Mr. Davis's creatinine clearance? This can be anybody.
I did not calculate.
Right here, 70-ish. Yeah, 70. Okay, so that means he's well above the cutoff for dose reduction of rivaroxaban. So rivaroxaban 20 milligrams a day would be just as appropriate as Apixaban 5 milligrams twice a day, or as INR dose-adjusted warfarin. So all those are good answers. So I heard the person that said rivaroxaban, they picked it because it was a once daily medication, so a little bit easier to remember to take. The person in Augusta said they picked warfarin because they saw that it had level A evidence on some guideline out there.
I'm trying to find
and then, so the person that picked Apixaban, why did you pick Apixaban?
Okay.
In the guideline I looked at, it said that DOACs were recommended above warfarin for the AFib, and I also saw that Apixaban had like less drug-drug interactions and well tolerated.
Okay, so less drug-drug interactions, well tolerated for Apixaban, DOACs have a higher level of evidence than warfarin. Okay, so I think for me personally, I would probably pick Apixaban as well. I think Apixaban, this gentleman's an older gentleman. He's 73, and so Apixaban has a better side effect profile. It has less. Well, I guess what do you guys know about its side effect profile?
It has less bleeding, and his blood score was like 3.
Okay, so less bleeding. So in what sense? So there's a couple of ways when they look at anticoagulants, they classify bleeding according to a couple of different sites. So do you know specifically what?
Like less intracerebral bleeding than warfarin, and I think less GI than the other DOACs too.
Yes, yeah. So Apixaban has less intracranial bleeding, less GI bleeding than the other DOACs, and especially warfarin. So definitely, I think Apixaban would be a great choice for Mr. Davis for his anticoagulation based on his risk factors, his CHA2DS2-VASc, his HAS-BLED. So now that we have a option for his anticoagulation, how do we monitor DOACs?
Renal function test.
So I see somebody shaking their head, no, we don't. Okay.
What?
So what do we need to look at before initiating DOACs?
We're supposed to look at liver and kidney function at baseline and then at least annually.
Yeah, exactly. So you want to look at renal function to make sure you have the right dose, like we talked about with the rivaroxaban. And apixaban's a little different. So what are our dose reduction recommendations for apixaban? Does anybody know?
Serum
Like over 80.
Increased age, decreased weight, or worse renal function.
Yeah, so serum creatinine greater than 1.5, age greater than 80, or weight less than 60, you have to have 2 of the 3. And then warfarin, how do we monitor warfarin? Yeah, so somebody here in Athens said INR. So generally, when you're initiating somebody on warfarin, you're going to want to see them more regularly, right? Because INR is, pretty volatile. It changes pretty quickly, especially if you don't know what else going on with the patient at that time. So the person in Augusta that picked warfarin, 5 milligrams a day. When did you want to see the patient back for an INR check?
in a week.
In a week, yeah, that's totally appropriate. Somewhere between 3, 5, 7 days, I think, is appropriate for warfarin. So my primary practice site is at the VA clinic here in Athens. And the way that we do DOAC monitoring is a little bit differently because we get their renal function and we look at their LFTs, their liver function tests, at baseline. And then we check them again about a month later. And then we check them at 3 months, and then we push them out to a year. So we monitor them a little bit more closely in the beginning just to see if anything's going on, see if they're having any issues with bleeding. And then once we realize that they're stable on the medication, we follow up with them at least annually. Okay. So we put this slide up here. Let's see if there's anything. Oh yeah. So huge with anticoagulants. What do we want to monitor for? Bleeding, absolutely. Yeah, so along with LFTs and renal function, these slides are on ELC, by the way. I just put them up there, so you don't have to take pics.
Already did, so.
We monitor CBC as well, so hemoglobin and hematocrit, right? So if they drop low, we know they're losing blood somewhere.
Here like 2 years ago.
But hopefully with our pick of anticoagulant, we can try to mitigate those risks in some way, shape, or form. So along with bleeding, so that's looking at the safety side of anticoagulants, what do we look at for efficacy?
Your 5 mg? Yeah, I was like 5 daily. I was like, I don't know if that's too much or not.
It's on the slide up there. Anybody? Anybody?
We make sure that they don't have a stroke or any sign of an embolism.
Yes, absolutely. So the whole point of being on anticoagulation is to try to prevent a stroke or some sort of PE or DVT. Okay? So, like I said, I think me personally, I would go with apixaban, 5 milligrams twice a day for Mr. Davis, just based on his age and some other risk factors. His HAS blood score is a little elevated. I think that that's the best choice for him. And so being in the VA, we follow up in a month and then 3 months and then push him out to a year as long as everything's stable. Anybody have any questions about any of the anticoagulation / atrial fibrillation before we move on? Okay, so somebody in Savannah, tell me what your priority problem number 2 was.
He said diabetes.
Diabetes, okay. Anybody, let's see, Albany, did you have something different than diabetes?
We actually had diabetes, but if you want something different, hypertension.
Hypertension, okay. What about Augusta? What did you guys put as the second problem? Just somebody.
He has discontinued aspirin as his second.
But that's like his second problem.
Aaron said dementia is the second problem.
Should I say dementia so it's different than what he has? The possibility of his dementia worsening.
Okay, worsening dementia. All right, what about here in Athens?
Huh?
How about antiplatelet use with anticoagulant?
All right, antiplatelet use.
Cheater!
That looks good. Now, let's see. So I'm assuming that came from my slides that are on the LC, but that's okay. Now, you guys are resourceful. That's good. So he's on an aspirin already. That's on his med profile. We know that, right? And so, what's his indication for aspirin?
Secondary prevention.
Huh? Anybody? What was that? Prophylaxis. Okay, so is he primary prevention or secondary prevention?
Second.
He's secondary prevention because of stroke, right? But what about cardiac disease? Is he primary prevention or secondary prevention there? Or I guess heart, I guess.
Right.
Has he ever had an MI? Has he ever had stents? Has he ever had a cabbage?
No.
So no. So really, and he doesn't have a diagnosis of unstable angina, so him needing an aspirin on top of his anticoagulant is really doing nothing other than putting him at an increased risk of bleeding. So yeah, so we definitely want to get rid of the aspirin on top of the apixaban. And so there are a bunch of different guidelines that talk about that. AHA, so the American Stroke Association guidelines. So aspirin is not recommended after ischemic stroke or TIA, so it wouldn't be recommended there. They say only in patients that have CAD, which Mr. Davis does not. ACC, AHA, AFib guidelines say for prior stroke or TIA, they recommend an oral anticoagulant over an antiplatelet. And then the CHEST guidelines, they don't recommend the use of an antiplatelet concomitantly with an anticoagulant because of the increased risk of bleed, unless the patient has had stents or has had an MI in the past or unstable angina, something like that.
Then it gets all up in your teeth.
So,
Can I ask a question?
yes.
It's in my lunchbox.
Okay, so I found somewhere that it was like he needs an anticoagulant if the stroke was cardioembolic or aspirin if it was atherosclerotic, but it didn't say like specifically where it came from. Are you just basing that on like his other stuff going on?
Yeah, so he has AFib, right? So AFib means he needs an anticoagulant. So it's not atherosclerotic in nature. It's so what you said atherosclerotic or cardioembolic. Yeah, so it's cardioembolic. So AFib, blood pools in your atria. You get clots that form when your heart goes in and out of AFib and normal sinus rhythm. Those clots can dislodge, and that's your cardioembolic source. And then they can get lodged in the brain, they can get lodged in the lungs or in the legs. So, and that's something you have to pay attention to. So I think in this case, it wasn't explicitly stated that the patient's stroke was a result of his AFib, but the fact of his CHA2DS2-VASc being 6, and he has AFib diagnosis of atrial fibrillation, and he's had at least 2 strokes, I think that puts him definitely more towards the cardioembolic side as opposed to atherosclerotic side. Does that make sense? Any questions about that anywhere? Okay, announcements.
I think we were just like based on people saying diabetes like priority number 2. Would you need to necessarily put this as a separate problem, or could you just put the DC in the first problem?
Yeah, so you can kind of put initiation of anticoagulation for AFib, and then in your plan for that, you could have put discontinue aspirin therapy. Yeah, so it didn't have to necessarily be a completely separate problem. I did it separate for simplicity's sake, so we could talk about it. But absolutely, I mean, there are going to be a lot of things broken out in my stuff that I put for simplicity's sake. But in practice, yeah, I would say both of them go hand in hand, especially if you're starting an anticoagulant in a patient. There's another question. Okay, just kidding, it's gone. Any questions about anything else with regards to the aspirin therapy and why Mr. Davis does not need it?
I have a quick question real quick.
Yes.
You wouldn't want to use aspirin and Zoloc if they have MI, stent, or cabbage, is that right? You wouldn't want to use both those?
Yeah, so if they have a history of cardiac disease, whether it be a prior myocardial infarction or stents, or a cabbage, a coronary artery bypass grafting, then those patients will be indicated for aspirin therapy. And in some cases, hopefully not very many, maybe even triple therapy with a antiplatelet agent in there like Plavix or Relenza or Effient on top of aspirin, on top of an anticoagulant. So if you guys see a patient like that, it definitely needs to send red flags. You need to look, see when they had stents or when their last cardiac event was, and see if you can try to get them off of one of those, talk to their cardiologist, see if you can get them off of one of the, either the aspirin or the Plavix, because they're at an extremely elevated risk for bleed being on all three of those agents. Okay, so I think that's it for aspirin. You know, your assessment, the patient does not need the aspirin because he's now on anticoagulant, and it's not recommended because he doesn't have CAD in conjunction with an anticoagulant. And your plan, so we're just going to DC the aspirin, right? Follow up with the patient and monitor for any bruising and bleeding. That sound right? And signs of embolism or stroke. Okay. So problem number 3. What do you guys think?
Diabetes.
Okay, diabetes. So what's his A1C?
8.5.
8.5. Okay. Let's see. What? So we have an A1C. Does anybody on the other campuses have any different answers for their third problem?
No.
Or I guess if the second problem, if you put the aspirin with the apixaban.
What is the not think the problem? The dementia? He listed it as problem 7.
Okay, so his A1C is 8.5, right? He was just in the hospital for a stroke and uncontrolled diabetes. So what would be some of the things we need to look at in patients that have diabetes?
If they keep like a daily log of any of their blood glucose readings?
Yeah, perfect. So something we always want patients to keep is a log of their blood sugars. And so this came from the pre-class case. And so this is just the SMBG log that was on there. So I'll put that up here so we can have it for reference. Okay. So some of the subjective here. So what can we take based on the patient interview and these SMBGs? What's some subjective information that we can pull from that?
What?
You can get that average fasting blood glucose.
Yeah, so you can get his average fastings, right? And so that's going to help us with knowing, is he at goal? Are those fastings at goal? Are they not at goal? So that takes us to another question here. So what is this patient's A1C goal?
Less than 8.
So I hear less than 7.
Less than 8.
Less than 8. Okay. Anybody with anything different?
In the new guidelines from 2019, it says that older adults who have cognitive impairment, they can have an A1C goal between or less than 8.0 to 8.5%.
Okay. All right. So somebody that said less than 7%, Tell me why you picked less than 7% and what guideline you looked at to determine that.
The wrong one.
Not that new one.
Anybody on the other campuses?
No.
So anybody less than 7? Why you picked it? I mean, I'll wait for somebody to answer. I'm okay with silence, I promise.
Let's take it back.
Dude, man.
All right, come on.
I think I picked it because of the old ADA guidelines, and I think the A1C goal of less than 7 was just the kind of the one that I remember looking at.
Okay. So old ADA guidelines looked at the goal less than 7. So we have somebody that said for this patient less than 8 to 8.5% based on his cognitive impairment. So I think for Mr. Davis, I would probably go with a goal of less than 8%, just based on his age. He's 73. So as patients get older, the ADA says once they hit age 65, we can consider a more lax A1C goal of less than 7.5%, just strictly to try to avoid any hypoglycemia. Because we all know that as patients age, they're more prone to falls. Hypoglycemia can lead to patients falling. Elderly patients can break bones, hips, and then generally that leads them on a decline of health. So the ADA really wants us to try to prevent hypoglycemia in older adults. So at age 65, they say we can do less than 7.5%. But in Mr. Davis, based on his extensive comorbidities, prior strokes, his cognitive impairment, so he has a diagnosis of Alzheimer's dementia, I think less than 8% is completely reasonable for Mr. Davis for his A1C goal. So if we have our A1C goal at less than 8%, what's our fasting goal?
90 to 150.
Yeah, 90 to 150. So what's our usual fasting goal?
80 to 130.
Yeah, 80 to 130. So essentially the ADA has moved it up. So the lower bound is 90, and that's just to try to prevent the hypoglycemia, pushing patients too low. And since we're a little more lax, they've bumped the upper end up too, just to try to give them a little bit more leeway there. All right, what about our postprandial goals? Somebody in Augusta, what's our postprandial goal for A1C less than 8?
Less than 200.
Yeah, less than 200. All right, so now we've got his goal A1C. We've said his A1C is 8.5. It's above goal, right? We know what his fasting goal is. We know what his postprandial goal is. So now, what's your assessment of his SMBGs that he comes and presents to clinic with?
I would say he's uncontrolled.
Yes, great. His A1C is 8.5%. If his fasting goal is 90 to 150, you take a look at those numbers. The average is in the 190s, so I'd say he's well above goal, uncontrolled for sure. So now, what's his current medication regimen? What's he currently taking for his diabetes?
Just insulin.
So he's on insulin therapy. What types of insulin? Lantus, and Novolog, Glargine, Aspart. Why is he not on metformin?
They discontinued it in the hospital.
Okay, so it got DC'd on his most recent hospital admission. Okay, so now what did the current ADA guidelines tell us about metformin therapy?
He should be on it.
Yeah, Good. You should be on it forever and always. But the main caveat there being what? So what do we have to look at to determine if a patient is eligible to receive metformin?
EGFR.
Yeah, absolutely, EGFR. So what is Mr. Davis's EGFR?
Good.
About 88.
Okay, perfect. So greater than 60, so metformin is fine, right? So, I mean, that we can see if that's a potential thing that we want to do. Let's see, so his serum creatinine and his EGFR are normal. We talked about his current therapy that he's on. His fastings, we said, are above goal based on what he has reported to us. So what do you guys want to do as far as medication changes for Mr. Davis for his diabetes? So we talked about his diabetes is uncontrolled. We have to do something, right? So what do you guys want to do?
Restart his metformin.
Okay, restart metformin. How do you want to restart it?
Start at 500 and then increase until you get back up to his 1,000 twice a day.
Okay. Now, so do you want to have him take 500 day 1, 1,000 day 2, and then 2 grams day 3?
No.
So why do we titrate metformin? What's the big deal?
GI.
Yeah, GI upset. And the patient, I think, even said that he had some trouble in the past taking metformin because they had just started him on 1 gram twice a day out of the gate with no titration, right? So somewhere between 3, 5, 7 days, somewhere in there is appropriate time frame in between your titration. So 500 for 3 days, and then 1,000 for 3 days, and then some people go 1,500 or like 1 gram in the morning, and then 500 in the evening before they go all the way up. Some people just go from 500 BID to 1 gram BID. It just depends on what their preference is. So for metformin, we already talked about what's our monitoring for metformin. What are we looking at? We kind of talked about it, EGFR, right? So how often are we monitoring a patient's EGFR while they're on metformin?
What?
Somebody in Savannah. How often do we monitor EGFR?
Every 6 to 12 months.
Yeah, generally yearly is fine. Okay, so with all that being said, so we talked about subjective with his SMBGs, we talked about some objective with his lab values, his A1C. We've put out our assessment, right? He is uncontrolled based on his above goal A1C, his above goal fastings. And so we want to restart metformin. We're going to monitor his serum creatinine EGFR at least yearly. What are some of the other screening things that patients with diabetes should have done? Some of the other things we look at, labs we look at, and then screening things as well.
Should use an annual eye exam and an annual foot exam.
Yeah, so annual eye exam, because uncontrolled diabetes can lead to diabetic retinopathy. We all know patients with diabetes develop neuropathy as well, so nerve damage, so that's why they need a foot exam. What else? What else does diabetes affect in the body if it's uncontrolled or even controlled as it progresses?
Would you monitor the UACR?
Yes, you would monitor the UACR, absolutely. So what does UACR stand for?
Urine albumin creatinine ratio?
Yes, urine albumin creatinine ratio. So that's a relatively new update to the guidelines. So they used to say monitor microalbumin or albumin in the urine, and so you would look at a certain threshold. If it's between 30 and 300, then it's microalbuminuria. If it's greater than 300, it would be macro, but they kind of simplified it a little bit and said look at the urinary albumin creatinine ratio, and that way you can take the ratio, see if it's elevated. If it's elevated, then what do they recommend for patients that have an elevated UACR? Somebody in Augusta.
If they have like an elevated UACR, but I didn't even look at that.
So what do the ADA guidelines recommend if you have an elevated UACR?
I don't know.
I guess what does an elevated UACR mean? What does that mean?
Yeah, I'm gonna.
There's kidney damage.
Yes, there's damage to your kidneys, right? So what is a common drug class that we see all the time that patients can be started on that actually has renal protective effects?
ACE inhibitors.
ACE or ARB?
Yes, ACEs or ARBs. Beautiful. So Mr. Davis is already on an ACE inhibitor. We don't have a UACR, so we can't see if it's elevated or not, but he's already on an ACE inhibitor for other reasons. Okay. Okay. So this is kind of my rationale that I went through when determining what to do about his diabetes. And so the patient comes back to you and he brings you these new logs with some fastings and some postprandials and some pre-dinner readings. So I want you guys to take a few minutes in your group, look at these, and see what you want to do about his diabetes medication regimen. We'll come back together in, I don't know, 3-5 minutes, something like that.
He needs more insulin. Oh my god, what time is this class at? Me? Everybody? No. She said, what? Will you do a seminar for me? $50.
I'll do it for lunch. Easy. Now, I don't think that.
His seminar was great.
I was just about to say, now if you don't pass, that does not change. It does not change. It does not get reflected on mine.
I'd be scared too. That's funny.
Oh. That made me feel a lot better.
All right, so let's go ahead and come back together. So can I get somebody in Albany to tell me what you decided to do with this patient's diabetes regimen? So these are his logs. After he's come back in, he's on max metformin, a gram twice a day. So what'd you guys decide to do?
Oh my god.
So his fasting glucose is still high, so we would increase his basal dose at night first and see how that goes. And then if we need to, we can add a lunch dose and possibly increase his dinner dose.
Okay, so his fastings are still elevated. And so how much did you want to increase his basal insulin?
2 to 4 units. Or 10 to 20%.
10 to 15%.
Okay, and how many units is that?
You're so annoying.
2 to 4.
Okay, so pick one.
4.
4, beautiful. So you're going to increase his Lantus 4 units at bedtime. All right, so what do you make of these postprandial values?
Bad.
The breakfast ones look pretty good. The dinner ones are a little bit elevated.
Yeah, bad. They're bad. Yeah. So they're a little high, right? So that means you can look at increasing, right, his dinner time no log. And how much would you increase that?
Two units.
Okay, perfect. 2 units. That sounds good. Okay. So now that we've got that kind of talked about, we're going to continue the metformin. We're going to do those increases on his insulins. So when do you want to recheck an A1C? How often do we check an A1C?
Every 3 months.
Yep, every 3 months if they're uncontrolled. What about if they're controlled?
Every 6 months.
Yep, every 6 months. Awesome. And so we definitely want to keep the patient monitoring his blood glucose like he is. We want him to get a yearly eye exam, a yearly foot exam, check a yearly UACR, an A1C every 3 months, and serum creatinine, eGFR, somewhere between 6 and 12 months, usually just yearly. All right, so that's kind of the first 3. So we've got anticoagulation, antiplatelet while on an anticoagulant, and uncontrolled diabetes. So what next?
I have a question about his diabetes.
Yes.
Instead of adjusting his insulin, can you add Jardiance?
Okay, so let's talk about that. So why would you want to add Jardiance?
I actually found a trial that Jardiance showed a 35% relative risk reduction in heart failure patients and reduced hospitalizations.
Okay, yeah. No, you're absolutely right. Jardiance, especially in most of the SGLT2s now, Invokana and Jardiance, those are the 2 that have the decreased heart failure hospitalizations. Jardiance is the only one that has the decrease in the cardiovascular mortality, but Invokana has the decrease in heart failure hospitalization. So it's absolutely an option to add Jardiance. So if you chose to add Jardiance, what dose would you start at?
10 milligrams a day, and adjust the insulin so he wouldn't have hypoglycemic episodes.
Okay, yeah, so Jardiance, 10 milligrams a day, and then you said to adjust the insulin so he wouldn't have hypoglycemia. I think that would be appropriate. So what are some of the common side effects and counseling points for Jardiance that you would want to make sure to mention to the patient?
UTIs.
UTIs, yes, huge, especially in female patients. UTIs and yeast infections, not as common in males, but still that potential is there. What else?
an increased urine output?
Yeah, just by the mechanism of the way it works, increased urine output. Okay, there are a couple big ones.
Is that the one where like your foot can fall off or something?
There is an increased risk of amputations associated with the SGLT2 inhibitors, mainly of the toes. Nothing much more than that, but with that, it was mainly in patients that had prior amputations or had peripheral vascular disease, and so Mr. Davis doesn't have either of those, so I think that he would not be at an increased risk of amputation. But yes, this class of drugs is known for that.
I think that's more for Invokana versus the Jardiance, because I didn't see a black box warning for the Jardiance for that.
Yeah, Jardiance, it won't have the black box warning, but it definitely showed up in the clinical trials. And they don't know why.
I don't like this dude.
What else? So there's two more for counseling for the SGLT2s. So kind of along the same lines of amputations, Fournier's gangrene, which is genital gangrene. Nobody wants that, right? So you definitely want to tell the patient about it. And then euglycemic DKA. And so that's, we think DKA, we think, blood sugars 450, 300, right? So these people can be in DKA with blood sugars in the 250s, 200s, just based on how this drug works. So there's increased urine output, right, based on the mechanism of action. It's removing or preventing the reabsorption of glucose, so you're getting rid of glucose in the urine, getting rid of extra urine, so these patients get dehydrated very easily. And so when you get dehydrated, patients with diabetes, their risk of DKA goes up significantly. So that's something that we definitely want to make sure to counsel the patient on signs and symptoms of DKA, just so that they're aware. But yes, Jardiance is a totally reasonable option here. Absolutely. Based on his history of stroke, I think, totally reasonable. Anybody else have anything different besides titrating his insulin? Anybody?
Lifestyle changes.
Lifestyle, always, right? Are they likely to happen? Probably not. But we can try. So I think, you could also potentially think about using a GLP-1 here as well. So the main GLP-1 right now that has cardiovascular benefit data associated with it is Victoza. So potentially you could think about Victoza here as well. There's a new trial for Trulicity that's coming out, the Rewind CV trial, that's pretty promising with cardiovascular benefit. So potentially you could trial a GLP-1 here and maybe even get him off of his bolus insulin and be able to decrease the dose of his basal insulin. In clinic, we've started several patients that are on fairly low dose basal bolus regimens, and we've been able to stop their insulin completely once we start them on a GLP-1. And most patients are pretty happy about that. So I think a GLP-1 would be a totally reasonable option here too. So as you guys can see, it's pretty wide open. The easiest thing to do is just adjusting the insulin. It's there, he's got it. Guidelines say 10 to 15%, so that's what we do. But if you're looking for extra added benefit, cardiovascular benefit, you can try to go one of the more non-traditional routes, like your SGLT2 inhibitors or your GLP-1s. And in the new standards of care, they've actually moved them up in the recommendations for treating patients with those drugs that have a history of cardiovascular disease. Okay. Any questions about diabetes before we move on? All right. So what's next? What's the next problem?
He's having a stroke right now.
Let's get somebody from. We'll go Savannah.
We were going with heart failure.
I did hypertension.
Hypertension, okay. Anybody else? Anything different? The other campuses? Albany or Augusta? Do you guys pick anything different there?
Dyslipidemia.
ACVD risk. It's high, bro.
No.
Okay. All right. So I think I put lipids next. Secondary prevention. Based on his presentation in the pharmacotherapy note from pre-class, he wasn't complaining of any symptoms of heart failure. His echo was, we'll get into all this, but I think heart failure could be a little bit lower down the line. His hypertension, I kind of couple that with his heart failure because that's something that we definitely want to control. But why would I say his lipids would be next?
Because he's the second.
Probably because of his risk having already had CVD.
Yeah, so he's had 2 strokes, right? He's had 2 strokes, so that puts him in what statin benefit group? Secondary prevention, yes. And what does that mean he's indicated for? High intensity statin, right? So what does his most recent lipid panel look like?
It was okay. His HDL was 1 Right. Other than that, it was okay.
It was mainly within normal limits, except for a slightly low HDL.
Yeah, so I think his LDL was 74. And we look at that and we say, okay, that's pretty good, that's 100, right? But there's a new update to the lipid guidelines that just came out, and they say that for secondary prevention patients, you definitely want to push their LDL at least to less than 70. With a 50% or greater reduction in their LDL from baseline. So Mr. Davis, we don't know what his baseline is. We only have LDLs from when he was on statin therapy. But I would say based on his prior history of stroke, that it would definitely be beneficial to increase his statin intensity to a high intensity statin. So to do that, what could we do?
Increase the atorvastatin to 40 milligrams?
Yeah, atorva 20 to 40, easiest thing. He's on it, he's tolerating it, no issues. So when would we want to recheck a lipid panel? After we make the adjustment in his atorvastatin. Yeah, somewhere between 4 and 12 weeks. That's what the guidelines recommend. In practice, generally it's going to be somewhere between 6, 8, 10, somewhere in that area. Because it's generally hard to get patients to come back in 4 weeks after their last appointment, and especially get them new labs. So what else are some things that we monitor for patients that are on statin therapy?
Liver function tests.
Huh? So somebody in Athens says myopathy, okay. What else?
LFTs.
LFTs. So how often do you check LFTs?
6 months to a year, but usually yearly.
Yeah, so you get baseline. There's no true indication to monitor regular LFTs. So when statins first came out, there were recommendations to regularly monitor LFTs, but now that we know that there's no real indication for that, we don't have to, but generally they're going to see their primary care physician every 12 months or so, and they're going to get all the labs that they need, so LFTs will generally be on there. Okay, anything else with lipids? Yeah, that's it. Pretty straightforward. All right, so like I said, next I put heart failure, right? So what are some signs and symptoms of heart failure? So if a patient has heart failure and they come to your clinic, What are some of the things you're going to ask him about?
Can you breathe?
Shortness of breath and edema.
Yeah, shortness of breath from fluid accumulation in the lungs and lower extremity edema. All right, what else?
Could it be that it's had any weight changes?
Yes, weight changes. I'm not sure where that came from, but weight changes. So definitely we want to tell patients with heart failure to weigh themselves every day, first thing in the morning. What else?
You could ask if they're having a prop up their head with pillows.
Yeah, so orthopnea, how many pillows they have to sleep on at night. If that increases, then you know they're retaining fluid and something is going on and needs to change. Okay, keep going. What else? What about a physical exam? So we said edema. What else on physical exam do we see in patients that have, yeah? What? I think you said it. Did you say it? Just say, I think you're right. Yes, JVD, absolutely. Jugular venous distension. Yeah, so you can look in patients that have heart failure and they're accumulating fluid. You can see their jugular vein pulsating with every beat of their heart. So there's another physical exam sign you can do. It's called the hepatojugular reflex. So you press on their liver, and then you can see their jugular start pulsating. All right, so what medications right now, what's he currently on for his heart failure?
Metoprolol, lisinopril, and furosemide.
Okay, so we have metoprolol. Which metoprolol? And does it matter?
Succinate, and yes, it does matter.
Okay, so which beta blockers are heart failure beta blockers?
BCM, bisoprolol, carvedilol, and metoprolol.
Yes, yes. So bisoprolol, metoprolol, succinate, and carvedilol. Okay, and so in patients that are on beta blockers, is there mortality benefit associated with beta blocker use?
Yes.
Yes. Yes, absolutely. 25 to 35% mortality reduction, relative risk reduction with beta blocker use. So pretty significant. All right, so we have lisinopril. So let's see, for lisinopril, is that a correct drug in the ACE inhibitor family for him to be on for heart failure?
Yes. Yes.
Yeah, so ACE inhibitors, we generally say it's a class effect. So any ACE inhibitor is good. Generally, you'll see lisinopril because it's most common. Maybe an enalapril or fosinopril. Outside of that, not really a whole lot. So ACE inhibitor is on lisinopril, 40. Is there mortality benefit associated with ACE inhibitor use? Yes or no?
Yes. I don't know. I just need the beta blockers.
All right, so we have some yeses here in Athens. Yeah, so absolutely, same thing, around 30% mortality, relative risk reduction with ACE inhibitors, for sure. And we said he's on Lasix, right? So what's the Lasix for? Yeah, fluid retention to get rid of excess fluid. Is there mortality benefit associated with Lasix or diuretics?
Nope.
I hear some mms. No, there's not. But definitely morbidity, right? So quality of life. The diuretics are really going to help patients breathe better, move better. So that's why diuretics are widely prescribed. So what type of heart failure does Mr. Davis have based on his first echo? How do we look at that? What do we look at on the echo to tell us what type of heart failure they have? Yeah, the EF, ejection fraction. So what is Mr. Davis's EF?
to 45.
Yeah, 40 to 45%. So what heart failure categories that put him in? Yeah, so it's it's like preserved, but in between preserved and reduced, but we'll just stick with preserved. Yeah, so honestly, there's not a whole lot of guidance on drug therapy for patients that have preserved ejection fraction. There's a lot of trials have been done looking at medications to try to reduce their mortality, and essentially all of them have come out not great. So really the biggest things the guidelines recommend for patients with preserved EF is treating their hypertension, right? So we have, let me see. So with our beta blocker, what are some of our monitoring parameters there? What do we want to monitor with beta blockers?
Heart rate.
Monitor heart rate, make sure it doesn't get too low.
Yep, heart rate, right? So bradycardia, fatigue, just general malaise, feeling terrible. Those are some of the things to look for. Oh, what about ACE inhibitors? What do we monitor?
Serum creatinine, potassium.
Potassium, yep, absolutely. What else? Serum creatinine and potassium, yeah. We also want to look for signs or symptoms of hypotension, right? What about Lasix? What do we monitor for Lasix? So your potassium. What else? Sodium, yeah. Literally all the electrolytes, right? That's what we look at. And serum creatinine. Okay, so the echo that we have on Mr. Davis is about a year old, and he comes back to the clinic, and here, hold on a second. And this is what his new echo is.
I cannot read that.
So what are we looking at here? Yeah, so we're looking at his EF, right? It's gone down to 25 to 35%, right? He's reporting increased shortness of breath during minimal activities that he used to do with no problem at all, right? So with all of that in mind and his elevated blood pressure, what do you guys recommend doing for Mr. Davis?
Add spironolactone.
Start spironolactone.
Yes, spironolactone. What dose?
25 Q day.
Okay, 25 Q day. Anybody want to do anything different? Nobody? Nobody want to do anything different?
Just ask him.
Could we do
What
Bido?
about a different? You could, okay, you could look at Bidil for Mr. Davis. So where did that come from?
Augusta, Georgia.
What campus?
Augusta, Georgia.
Augusta.
Augusta, okay. So Bidil, so what are the components of Bidil?
Isosorbide and hydrazine.
Okay, which isosorbide?
Dinitrate.
Dinitrate, yes. Okay, and so which patients is Bidil indicated for?
African Americans.
Yeah, so African American patients, those are patients that we're going to look at adding Bidil to their heart failure regimen for additional reductions in mortality. So Bidil is an option. I think I chose spironolactone. And I think I started at 12.5 milligrams a day, so half of 25. So what are our biggest monitoring parameters with spironolactone? Huh? Serum creatinine and potassium are huge. Potassium can swing on you in a second in a patient that you start on spironolactone. So you definitely want to check it. When do you want to check potassium and serum creatinine after you start spironolactone?
2 weeks.
Yeah, so 2 weeks. At the VA, we check it a little bit sooner. And I think it's recommended 3 days after initiation, then a week after initiation, then a month. So it's pretty close monitoring there for heart failure and spironolactone. And so why spironolactone? Which patients is it indicated for that have heart failure?
If their ejection fraction is less than 35%.
Okay, yeah, so EF less than 35%. All right, and what else specifically?
Isn't it the class of heart
So
failure?
potassium has to be less than 5 milliequivalents per liter and EGFR greater than 30.
Okay, what else?
New York Heart Association Class 3.
Class 2 through 4.
If they have hypertension or diabetes.
Yeah, so, well, I mean, those are all things to take into account, but it's indicated in patients that have reduced ejection fraction heart failure with an EF less than 35% and a New York Heart Association class 2 to 4. So, based on these symptoms, Mr. Davis is New York Heart Association class 3, right? So it would definitely be indicated for spironolactone therapy. Okay. So now, what about the next problem? What do you guys think? What's another big issue with his, just looking at his med profile, his medications?
The acetaminophen.
Yeah, Tylenol. How much Tylenol is he on?
A crap ton.
A lot.
So he's on 4 grams of Tylenol. Does he have anything else on his profile?
Norco.
Yeah, he's got Norco, right? So what's the easiest thing to do there?
Take off the Norco.
So I hear a lot of mumbling, DC stop.
Discontinue.
Discontinue which one?
Norco.
Yeah. So he's on it. So what's he on the Norco and the acetaminophen or Tylenol for?
Osteoarthritis.
Yeah, osteoarthritis. So I think since Mr. Davis is 73 and he's got some risk factors for falls, we definitely want to try to reduce that risk any way we can. So we want to get rid of the Norco. So Mr. Davis comes back in at the next clinic visit, and he tells you that his pain is currently 4 out of 10, but it increases to 7 or 8 out of 10 at his knee, and it's unbearable after you stop the Norco. So what do you want to do and why?
Topical NSAID.
For his osteoarthritis.
We can add in topical NSAID now, like diclofenac.
Yeah. So now why a topical? Why not a systemic NSAID? Why not an oral NSAID?
Because he's old. His age mostly. And what? And he's on anticoagulation, so we don't want to increase the risk of a GI bleed if he's on an NSAID.
So he's on an
systemic one.
Yeah, so he's on an anticoagulant, and we know that anticoagulants and NSAIDs don't really mix well, right? Increased risk of GI bleed, so that's why a systemic NSAID in this particular patient is probably not our best option, which is why the topical, like the Voltaren gel, especially since it's just the knee, is probably the best route to go. Now, what's our dosing for the Voltaren gel?
I don't know.
A max of 16 grams per joint per day.
Yeah, so generally it's 4 grams QID, something like that. So depending on which joint, it can be more or less. Yeah, so what are some monitoring things we want to have Mr. Davis monitor for Mr. Davis when starting the Voltaren gel?
His pain.
Somebody in Savannah. So what do we want to monitor?
Pain levels?
Yes, absolutely, right? So we're starting it to control his pain better. So we want to monitor his pain control. All right, anything else?
Symptoms of liver toxicity or like his liver function test?
Yeah, so oral diclofenac has been linked to liver toxicity, and it's just something that you may want to pay attention to with the topical. It's not as likely, but something to pay attention to.
I have a question.
Yes.
Would it be reasonable to discontinue the DocuSite as well when we're taking out the Norco, if that's like why he was on that?
Potentially, yeah. So does he have an indication for the DocuSite that's documented?
No.
No. So he was probably on the DocuSite as a stool softener because he was on the Norco, right? So I don't know if I would get rid of it this visit, just because we don't know why he's on it. Likely it is because of the Norco, but you know, old people really like their regimens. They like to poop at certain times. And so you don't want to get rid of it without making sure he doesn't need it. Anybody else?
I don't agree with half the
Okay.
stuff that's come out of your mouth.
So what next? What's the next problem? This guy has a bunch of problems.
Can we talk about his Alzheimer's, please? I'm like, I'm pretty worried.
And we've already said it a little bit, a couple of times.
The Alzheimer's dementia?
Yeah, it's Alzheimer's, right? So we have the MMSE that's in there from the pre-class workup that showed his score was 24 out of 30. And so what does that correlate with? 24 out of 30 is
Mild dementia.
mild dementia. Okay. I thought it was normal. Am I wrong?
Yes.
Okay.
You're
Yeah,
wrong.
it's normal.
What?
Normal cognition. So what is he on for his Alzheimer's right now? Donepezil, 5 milligrams a day. Okay. So he comes back in, and his MMSE score has gone down to 20 out of 30. So what is that? What does that categorize as? Yeah, mild cognitive impairment. So his MMSE is declining. His cognitive abilities are declining. He said he feels like his memory is getting worse. So what do you guys want to do? What do you think?
Increase the donepezil to 10 milligrams.
Yeah, absolutely. So increase the donepezil to 10 milligrams. It's indicated in mild to moderate or moderate to severe Alzheimer's dementia. What are some of the biggest side effects that you want to monitor for with donepezil? Yeah, GI for sure. GI, nausea, vomiting, diarrhea. Definitely want to monitor for those. And that's why you titrate patients on donepezil. So you start them at a low dose and titrate them up. Don't ever want to start somebody on 10 milligrams straight out of the gate. Okay. So what else? What else does Mr. Davis? Yes.
Dana, so what score suggests mild dementia? Because what I looked up said 22, 24 suggests mild dementia. Is that wrong?
20 to 24. I was looking at the one on the EHR Go that I think said 24 to 30 was normal and less than 24 was mild. Can anybody verify that with me here in Athens or somewhere else?
It didn't give us a theme.
23 to 30.
Here, let me see. I don't want to confuse anybody. Let me pull it up.
Like, where does it say on here that?
So this doesn't have anything on it. Okay. Well, that's great. I think, so what we do know, no matter what the MMSE score is, whether it's classified as normal or mild, he's had a decline in his cognitive function, right? So it's appropriate to increase his donepezil to try to improve his symptoms and improve his memory. That makes sense? All right, so let's see what time it is. So we have about 15 more minutes. So these last few problems are pretty simple. So why don't you guys just throw them out there and we'll talk about them one by one. The last couple, I couldn't really prioritize them. I did when I put them in my slides, but I mean, there's not really a whole lot that we know subjectively that's going on with these conditions. So it's, you know, you could mix up the order any way that you would want to.
He has no therapy for his GERD.
Yeah, so he's not on any therapy for his GERD. Is he complaining of GERD symptoms currently that we know of? No. So he's not complaining of anything for his GERD. So would you want to start him on anything?
I really just said that he could have like antacids, PRN, like if he ended up having symptoms.
Yeah, I think that's appropriate. I don't know that we need to jump the gun and say, you know, take a PPI. There's a lot that goes along with taking a PPI, especially for a long period of time. But I think PRN antacids are completely appropriate for him to treat his GERD if he does have symptoms. Okay, what else?
PTSD.
Yeah, PTSD. So what's he on for his PTSD?
Mirtazapine.
Maybe, yeah, mirtazapine. That sounds good. It's not generally one that I think about for PTSD. Generally, it's more for patients that have depression and are underweight because it can cause weight gain and increase your appetite. You'll see it a lot in patients that have cancer that can't eat, so choose something to try to stimulate their appetite. But I assume that it's for his PTSD based on the information that we're given. We're not given any subjective information about his PTSD. He's not telling us he's having any symptoms, any nightmares, anything like that. So I think it would be appropriate to continue the mirtazapine 30 milligrams at bedtime and just continue to follow up and ask him about his symptoms that he's had, if he has any. All right, what else?
Based on the fact that mirtazapine is on the Beers list, would you not consider discontinuing that and changing it to an SSRI or something else?
Are the SSRIs not on the Beers list? Yeah, so, but there again too, so the question, SSRI versus mirtazapine, Beers list, not Beers list. So if a patient is stable on a medication that they're taking for PTSD, I'm not likely going to touch that. I see exactly what you're saying. We want to try to minimize its risk for falls any way that we can. But I think since he's taking the medication at bedtime, that kind of mitigates a little bit of risk there. And he's stable on it, so I'm sure not going to touch it. But I see your thought process. It makes sense.
Why is he stable if he came in like confused and agitated and stuff?
So that is from, so that's just like a little brief thing that you get on ELC, right? So that's like the in-class bonus thing if we got to it. So that confusion and agitation has nothing to do with his PTSD.
How are we supposed to know that?
What is it?
It's another stroke.
And so we'll talk about that in a minute.
He's having a stroke?
Yeah, I just wanted, I'm so confused.
Like right now?
Okay. So we've done PTSD, GERD, no pharmacotherapy for GERD. On mirtazapine, we're going to continue it. What else? Yeah, neuropathy. So he's on gabapentin. He is complaining of pain, but it doesn't seem like neuropathic pain. It sounds like it's more located in the knee. Sounds like osteoarthritic pain. He's on gabapentin 600 TID, so I'd probably just continue that as it's prescribed. and then follow up and see if he
Isn't
has
the
any
dose
issues
too high?
in the future.
Isn't the dose too high? The gabapentin? Is that dose appropriate? Because on LexiComp, I was seeing 100 to 300 milligrams 1 to 3 times a day, and he's taking 600.
Yeah, so you can actually go way over 3 grams of gabapentin a day, as long as the renal function can tolerate it and the patient's symptom or side effect profile can tolerate it. So main side effects we're looking at for gabapentin are CNS effects, confusion, dizziness, things like that, fatigue. So as long as the patient can tolerate it and their renal function is within normal limits, and we said Mr. Davis is a 70, and I think that's well above the cutoff for dose reduction of gabapentin. So I think it is appropriate. Okay, so now on to the confusion, agitation. So Mr. Davis comes to your clinic for a follow-up appointment, and he is having word-finding difficulties. He's slurring his speech. He's becoming very agitated, which is unlike his normal self. So what do you do? You're in the room with Mr. Davis. What do you do?
We refer him to the hospital.
Yeah, so that is not something that we are trained to deal with, right? It's an acute situation in the outpatient setting. That's not something we are expecting to happen, but we're going to want to triage him to his PCP as soon as possible, and the PCP will evaluate and determine if he needs to go to the emergency room, to the hospital. And so what therapy, if it's determined to be a cardioembolic stroke due to his AFib, so what kind of drug do we give them to try to dissolve the clot so the symptoms go away? Yeah, so TPA, and there's a certain time window for TPA administration. 4 hours, and you can even push it out to 6 maybe, but much more data suggests within 4 hours. So yeah, so the big thing there is if you ever encounter a situation like this in your clinic setting where you're not sure what's going on, patient is acting very strange, and it looks like symptoms of a stroke, or if they're complaining of chest pain, we have pain down their arm, always know to triage the PCP because they're going to be the ones to make that evaluation and determine if the patient is appropriate for transportation to the ER or the hospital. And then once you triage them, they can take over from there. But just make sure you can make that decision quickly and efficiently. Okay? Anybody have any questions from any of the other campuses or in Athens about Mr. Davis?
When you say PCP, you mean like you're in a clinic with the PCP in the same building, right?
Yes. Yeah, so that's the way the VA is set up. We have primary care providers, physicians, nurse practitioners. We have PharmDs there who run pharmacotherapy clinics. We have mental health providers, psychiatrists, and psychologists. And so if we get something that we feel like is outside of our scope, that we aren't trained or equipped to deal with, we can just triage the patient over to the PCP, and they can evaluate them quickly and see if they need additional help.
Would you do anything about the fact that this guy has been smoking 2 packs a day for 52 years?
Yeah, so that's pretty bad, right? We can ask him if he wants to quit. So what would you recommend if he wants to quit? Patch, okay. So patch, that's fine. You can recommend gum, you can do lozenges. I kind of had to pick and choose what problems we talked about since there were so many of them. But yeah, absolutely. You always want to ask patients if they want to quit smoking. And if they do, know what some of the therapies are you can use to treat and help with smoking cessation. Okay? All right. Have a good rest of the day.
Okay.
Yeah.